Now we're going to move on to the pancreas. Oh, what fun the pancreas is. I'm going to share my screen again with you guys. All righty, and pull up that PowerPoint and we will continue. All right, so before we get to this, I'm going to add a slide. And I'm going to say the pancreas. Okay, so the pancreas is an endocrine organ. And with relationship to the endocrine system, you guys should all know this from term 3, I hope. The pancreas makes insulin and glucagon. Okay, so that's your beta cells. So makes, let's do this. Beta cells, which make insulin, and alpha cells, which make glucagon. And so, oops, I didn't need to do that twice. So with the endocrine function, in relationship to the endocrine system, the pancreas is instrumental in making sure that your cells get the sugar that they need from the foods that you eat. Insulin gets released from your pancreas to go like an Uber driver through your bloodstream, pick up the sugar from the things that you've eaten and bring it to your cells to feed them, okay? And then if your sugar drops low, it can also make glucagon to bring the sugar up a little bit to keep your blood sugar stable. But in this lesson, we're going to talk about the pancreas and its function as an exocrine organ, okay? Okay, so it is both endocrine and exocrine. So as an exocrine organ, it's responsible for 2 things, amylase and lipase. Amylase and lipase, they are, I'll call them chemicals, that enable your digestive system to metabolize starches and fats. Starches and fats. Okay? And you can even see with the name like lipase, lipid, liposuction, fat, and amylase, that's the one that helps with starches. Okay? If your pancreas is damaged, you've got big problems too. Not only because of the inability to metabolize starches and fats, but also from a blood sugar standpoint, right? So it's your pancreas is super important. Well, first disease we'll talk about is acute pancreatitis. Pathophysiology is the pancreas gets inflamed. It's usually due to, I hate to say this, but back to the booze again. Chronic alcoholism is one of the #1 causes for acute pancreatitis. Alcohol is just sugar, lots and lots and lots and lots of sugar. It's delicious sugar, but it's sugar. And it will inflame the pancreas, and the pancreas can do something called auto-digest, okay? This is a really, really fun thing. I've seen this only a few times in my career. What will happen is the pancreatic enzymes, which are those amylase and lipase, pancreatic enzymes, amylase and lipase, instead of being excreted to metabolize starches and fats, they will actually start to digest the pancreas. So the pancreas will begin to eat itself. It is painful. It's painful to watch, and it is deadly. Autodigestion is deadly. That's one of the other, I'll call it one of nature's flaws in the makeup of our bodies. So with really bad acute pancreatitis, if the pancreas starts to auto-digest, it will just, the amylase and lipase will start to go sky high, and it will actually, they will start to break down pancreatic tissue. So the pancreas starts to eat itself. Very, very bad. Let me highlight this whole page. Okay. Etiology. Alcohol is the #1 reason. I'm going to highlight that, okay? But also gallstones, elevated triglycerides, which triglycerides are fats in your blood, can do it. Don't worry about endoscopic retrograde cholangiopancreatography induced pancreatitis. Say that 3 times fast. That it's pretty rare. But certain medications can cause damage. And then I love this word, idiopathic. Idiopathic is the medical term for, that's exactly what it means. So it happens and I don't know why. Isn't that fun? All right. Signs and symptoms of pancreatitis. Really, really, really severe abdominal pain. And it radiates across the chest, across the back, and across the flank. Your flank is your like lower back, right around where your kidneys are, right? The patient will present to the emergency room with guarding. Guarding means that, you know, like, oh, don't touch me. Don't touch my abdomen. And their abdomen will be solid as a rock, really rigid, hard. Their blood pressure will be precipitously low. Hypotension, they can even go into shock. Shallow respirations, low-grade fever, tachycardia, nausea, vomiting, and even jaundice can occur, okay? If it's not treated, it can lead to so many more complications: heart failure, cardiovascular failure, respiratory distress syndrome. It can damage the kidneys. The patient can begin to internally hemorrhage. And I will put up cheat sheets. I'm going to put this here. See cheat sheets for Turner sign and for the Cullen sign. Just like with the McBurney's point with appendicitis, you need to know these. These are potential board questions. Okay, so I'll put the cheat sheets up for this. And infection can occur as well. I'm going to highlight all of these. Okay. Diagnostic tests. In order for us to diagnose acute pancreatitis, they have to have 2 of these things going on. They have to have abdominal pain, which 99% of the time they have. Their serum amylase and or lipase needs to be greater than 3 times the normal. And you need to know the levels of amylase and lipase. So I'm going to highlight these guys here. Okay. And then, you know, abdominal imaging is positive. If the patient comes in with severe abdominal pain and their amylase and or lipase is this high, we can pretty much tell they've got acute pancreatitis. We can do the ultrasound or the CT scan to definitely confirm, but this is pretty definitive right here. What are the interventions? Aggressive IV fluids right away. Nutrition. If it's mild pancreatitis, we can give them oral nutrition. If it's really severe, they can only receive enteral feedings. We're not going to give them anything by mouth. Pain meds and antibiotics for the infection. Oh my God, my battery's running low. Jesus, let me get my plug and I will keep talking. So pancreatitis can also be chronic, okay? Chronic and acute. Acute means it hits you like a ton of bricks. You got it. It's here, but hopefully it's going to go away or it's going to kill you. One of those 2 things. Chronic, it comes and goes, okay? Which is kind of even worse because of the fact that sometimes it can just come on for what seems to be no reason. I'm getting my plug. Hold on. Okay, let me just plug my computer in and I will keep talking. All right, there we go. Okay. If the ducts become obstructed for some reason, that can cause chronic pancreatitis. Ulceration, tissue death can occur. And exocrine insufficiency, which means if the pancreas isn't able to make that amylase and lipase, you eat foods that have starches or fats in them, guess what? You can't metabolize them, which is very painful. Okay. Etiology of this, again, I hate to say it, but alcohol abuse is like the #1 reason for it. It can happen for other reasons, idiopathic, genetic, obstructive biliary disease, which it means gallstones, which we're going to get to in a minute. Gallstones, autoimmune disorders, hyperlipidemia, blah, blah, blah. Don't drink, don't smoke. Well, other people don't smoke. I can smoke. And if it's biliary disease, treat it. Signs and symptoms, they can be asymptomatic. They can have left upper quadrant pain that gets worse after they eat. Okay, and epigastric pain, just so you know, means right above the stomach, above, like right at, underneath the breastbone, epigastric pain or left upper quad pain. Steatorrhea is fun. That is fatty stool. Oops. And when you look at someone with steatorrhea, when you look at their stool, it looks frothy. You know, when you look at the ocean and the waves come in and they're all frothy, well, that's what their stool looks like. It's frothy, and it will float on the at the top of the toilet, because it's nothing but fat, because they can't metabolize the fats because of the amylase or the lipase being insufficient. Okay. Not even going to get into complications. I really want to get focused on gallbladder. But how do we treat it? Something for pain, either non-steroidals, some kind of an analgesic. They have to have low-fat meals. And small, frequent meals are the answer to almost every health problem, just so you know. Pancreatic enzyme replacement, and this is important. Very, very important. This is a comp predictor question, so let me tell you. Pancreatic enzyme replacement, the drug is called pancrealipase, okay? And it is a capsule that is opened and sprinkled on food. That is an ATI comp predictor question, okay? People that have cystic fibrosis, I want to be able to see you guys, your faces again. When people have cystic fibrosis, one of the more common things that is a symptom of it is pancreatic insufficiency. And so with pancreatic insufficiency, they don't have those enzymes. So the question has to do with, a patient with cystic fibrosis, open the capsule and sprinkle it over their meals. That's the only time we tell you guys that it's okay to open a capsule, right? So don't forget that. You're welcome. All right, back to the PowerPoint. And we could also put stents in, and then sometimes surgery is the only other option. There's your nursing diagnoses for acute and chronic pancreatitis. I'm not talking about pancreatic cancer, because we have a whole class dedicated to just cancer. So this you do need to know. This is the Whipple procedure. Excuse me. So here's your gallbladder, okay? This is your stomach. This is your pancreas, and this is your small intestine. And basically what the procedure does is, it's a common procedure, not very successful. In my career, I've seen it successful once, okay? What they do is they remove basically the head of the pancreas, a large portion of the pancreas, and then do an anastomosis, or a connection, either from the stomach to the small bowel, which is a gastrojejunostomy, or from what's left of the pancreas to the small bowel, which is a pancreaticojejunostomy. It's a mouthful. They can also do one at the level of the gallbladder, not as common, which is a cholecystojejunostomy. So Whipple procedure, basically, it's an intervention for pancreatic cancer, really, Mary? Pancreatic. When you see CA, that means cancer. and it's removal of a large part of the pancreas. Okay, so there you go. That one you must know. The Board of Nursing loves to ask about Whipple procedures. Okay. All right. Don't want that one. Don't want that one. Gallbladder. Here we are. We're almost done, guys. So the gallbladder. The gallbladder, let's add a slide here so we can talk about what the gallbladder does. So let's go here and add a slide and gallbladder. And just so you know, when we're referring to the gallbladder, the medical term is chole, and it's C-H-O-L-E, okay? Medical term is chole. I'm going to highlight that. So in other words, if the patient has like removal of the gallbladder, that is a cholecystectomy. Okay? If they have their gallbladder removed with a laparoscope, we call it a lap chole, which is a laparoscopic removal of gallbladder. Okay? And then what does the gallbladder do? Okay, the biggest function of the gallbladder is it excretes bile. And bile does two things. Bile is the main reason why you have brown poop. Fun fact, okay? So bile, it colors your feces. So without bile, feces are chalky in color. Isn't that fun? And then the other function is bile helps to metabolize fats, okay, lipids. And so one of the biggest problems is people that tend to eat very, very fatty diets. They have high cholesterol, high triglycerides, lots and lots of extra fat that they don't need. They're kind of overworking the gallbladder, and gallstones can develop. That's one of the most common things that can happen. If there's not a picture of the gallbladder in here, I'm going to add one in for you guys because I want you to be able to see the common bile duct. Yep, here we go. So, and by the way, let me tell you this. Cholelithiasis, when you see the word lithiasis, that means stones. So let me back this up a minute. Gallbladder disorders, cholecystitis, inflammation, cholelithiasis, stones. Lithiasis, this part right here. Oops. Damn it. Come on, not the whole word, just there. So cholelithiasis are gallstones. Nephrolithiasis, kidney stones, okay? So just so you know. And then those stones can actually get hung up in the common bile duct. And if the bile duct is clogged, you got a problem because then the gallbladder is going to get inflamed and infected. And now you have cholecystitis, and now you're going to have a cholecystectomy, okay? So etiology, the older you get, the higher the risk. If there's a family history, risk is increased. Bile stasis. The word stasis means not moving, right? If something is static, okay, means not moving. Everything in your body that's a liquid is supposed to be moving. Your blood is moving all the time. Your lymphatic fluid is moving all the time. Cerebrospinal fluid is moving all the time. Fluid in your body is never supposed to be still. And by the way, all fluid in your body only goes one way. Everything in your body is a one-way street, just like South Philly, okay? If the bile doesn't move and doesn't flow through that common bile duct into your intestines, if it's static, stasis, that can cause a stone to form, and then that duct will get clogged, and then you got a problem. High cholesterol intake, fatty foods, fasting. I know there's this, we're the only country in the world, like really intermittent fasting is something that we do to lose weight or like to cleanse. Your body is not meant to fast. It's very bad for your
Your
health.
body is not meant to fasting. It's not good for your health.
You have to eat and eat and eat small, frequent meals. That is the way to stay healthy for everybody. Seriously. Healthy, not healthy, old, young, small, frequent meals. I eat all day long. Little meals. And I mean, do I eat junk once in a while? Yeah. But I'm almost 60 years old, okay? I'm in good shape. I take care of myself. Take care of yourself while you're young so that you don't have to worry about this crap when you get old. All right? Listen to mama. Okay? All right. Back to the PowerPoint. A sedentary lifestyle is not good. You got to sweat a couple times a week. You must. And it's more common in women than in men. Can't tell you why. Signs and symptoms. So if somebody has gallstones, they're going to have elevated vital signs, vomiting, possibly jaundice, epigastric pain, nausea, indigestion, right upper quad tenderness, positive Murphy. There's another name to add to your list of names. So I will put a cheat sheet up for all of these names. Okay. And biliary colic. Colic, anybody that's had a baby that's had colic is all too familiar with it. Colicky is pain or gas that kind of comes and goes. So the person will have indigestion and gas with severe pain that kind of comes and goes and comes and goes. It's intermittent. Okay, that's what that is, and that's why it makes babies cry. When we talk about complications of gallbladder disorders, if the gallbladder becomes inflamed, that bile duct is clogged, a couple bad things can happen. The gallbladder can rupture, which is bad. That's this. Necrosis means death of. Perforation means like a ripping of. So basically a rupture of the gallbladder. That's bad. If the gallbladder ruptures, empyema, which is just a medical term for purulent drainage. So it's purulent infectious drainage. And now it's pouring into your peritoneal cavity. So that can cause septicemia, septic shock, and death. The drainage can cause fistulas, tunneling, where there shouldn't be tunneling. Adenocarcinoma. When you see this word, carcinoma, you think cancer. You don't want cancer anywhere. It can also cause pancreatitis. How do we diagnose it? Well, usually the easiest way is an ultrasound. We can see it on the ultrasound or a CT scan or an MRI. You're going to see, don't worry about this one, hepatobiliary aminodiacetic acid scan. Nobody's going to ask you about that. Elevated white blood cell count because of the infection and elevated direct bilirubin. So, but, basically just understand what cholecystitis is. The cause of it is stones, typically stones clogging the bile duct, what the risk factors are, what the symptoms look like, and then what do we do about it? So interventions, well, we're going to take care of their pain. We may have to give them medications that are called bile acid sequestrants. In other words, it's like a replacement for the bile that they don't have. Antiemetics like Zofran, ondansetron, and nothing by mouth. And then slowly we might be able to advance them to a low-fat diet. Or we might just have to take that gallbladder out, okay? Laparoscopic is the way to go. With laparoscopic surgery, a couple things, and these are ATI questions, so let me point this out to you. Most common, the patient will have 3 or 4 puncture wounds, so they won't have an incision. What happens is we take a scope, we make an incision, a puncture wound right by the umbilicus, and then usually 2 or 3 other puncture wounds for us to insert the surgical tools into it. And with the scope that's in through the umbilicus, we can see what we're doing on a screen, and then we use the tools that are going through those other puncture wounds to pull the gallbladder out. It's fun to watch. I'll tell you a story in a second. So laparoscopic, a lap chole is the most common, 3 or 4 puncture wounds. It's the easiest for healing, but common. Post-op. You're going to love this. Complaint. Get this. Right shoulder pain. Make sure you know this. This is an ATI question, boys and girls. Right shoulder pain. And you're like, what? Why would their right shoulder hurt? Let me tell you why their right shoulder is going to hurt. When we go in with a laparoscope into the abdominal cavity, we are actually pumping in gas because we have to like blow the cavity up so that we can get to that gallbladder and get it out, right? And so that gas, and because of the location of the gallbladder, once we remove it, that empty space fills with gas, and they will have pain that radiates to their right shoulder. That is on 2 versions of the comp predictor for sure, and the board will ask you about that. Okay, right shoulder pain, most common complaint after a laparoscopic cholecystectomy. Don't forget it. And fun story real quick, first surgical procedure I ever watched when I was a student was a doctor who will remain unnamed, and he is retired, doing a laparoscopic chole on a 320 some odd pound lady. And we were watching from above. The doctor literally put his foot up on the table, and he's pulling and he's pulling and he's pulling, and he can't get her gallbladder out. Swear to God, we were like, while we were watching it, finally, boom, he gets it out. She had a stone in her common bile duct, and this is no shit. It was the size of like a little rubber ball, and it had all kinds of cool colors in it, of like the rainbow, because of all the bile and the acids and the salts that had accumulated. But that poor woman must have been in so much pain when she woke the hell up from all that pulling and yanking on her. Her whole table's rocking. So, and that was the first surgery I ever saw. I was like, oh, snap. So, fun story. His son is still a surgeon, though, that guy. But I won't say who he is. All right. And then with traditional surgery means that we didn't use a laparoscope. We actually cut the patient open. So that is called an open chole, right? Or an open cholecystectomy. Just means when you see open, it means we cut you open. You have an incision, and the patient will have a T-tube for drainage. This is important. Pay attention, kids. Let me highlight this too. Okay. See this? This is a T-tube. Okay. The T-tube goes in through a little puncture wound, and it goes directly to the common bile duct. And the purpose of the T-tube is that it exits outside the body into a little drainage container. The purpose of it is to drain any excess bile that's still hung up in the duct, because typically the duct was clogged, but we got rid of the gallbladder, so we solved the problem. So nursing intervention for that T-tube, make sure you remember this. Empty, daily, same time, every day, measure the drainage. And the drainage is going to look, and the drainage is going to look green in color because it's bile. Color is green. That's normal. Okay? It's not pus, that's bile. Okay? These 2 things, super important. These are predictor questions and these are board questions. Don't forget them. Okay? All right. There's some nursing diagnoses for gallbladder disorders, review questions for liver and everything else. And guess what we are? We are DUN, done. How about that? We did it. Let me save that. And let me give it a name. Save and save as. I'm going to put it in my cheat sheets. And I'm going to upload it to Teams. And we're going to call this, can't see, it's dark in here, liver, pancreas, and gallbladder. Okay. I am going to stop the recording. right now.